Thanks everyone for joining us. We welcome today Dr. Kathleen Poston. She is the new chief of the Movement Disorders Clinic Center at Stanford, and she's been at Stanford for a long time now. And she is one of the co-authors of an exciting new paper in the journal Neurology that was just published in January of 2024. And it's about a new definition of Parkinson's disease and dementia with Lewy bodies. So we're glad to have her here today to explain all about the proposal and what it means for researchers, clinicians, and us lay people. Take it away.
Thank you so much, Robin. I appreciate you all attending on a Friday afternoon. I also do apologize if you hear some meowing in the background. As Robin said, I just flew in from being out of town for a couple of days, and my cats are letting me know very loudly that I've been gone for a few days. So if there's some fluffy tails that come in the camera, I apologize in advance. Okay, so what Robin asked me to talk to everyone about today is something that's gotten a little bit of press recently about the idea of a biological definition of Parkinson's disease and dementia with Lewy bodies. And what I wanted to really focus on today is giving a little bit of the background as to what this was, why this is happening, what this means for research, but most importantly, what does this mean for folks who have the diagnosis of Parkinson's disease? How does this, if anything, change anything about the way you think about your Parkinson's disease? Because there's a lot of information out there, and I just kind of wanted to distill it down to something that was bite size and able to sort of wrap your head around. Okay, so quickly, this is our Movement Disorder Center. We have several new faculty who have joined us in the last year. We have another new faculty who is joining us in October. So I hope that many of our access issues that we've had over the last couple of years will be resolved soon. We are still growing and still recruiting new people out to California. So we will have plenty of movement disorder specialists for all of you, hopefully in the future. Okay, so this is the position paper that Robin, sorry, move that guy out of the way, that Robin mentioned that I will be talking about. So I first just want to start off by saying that this was very much a massive collaborative effort. This is the names of all the folks who are on this. And I just want to point out that this was a massive collaboration that was sponsored in part by the Michael J. Fox Foundation, as well as other patient-oriented foundations across the world, including in Australia, UK, and other places. Also included individuals from the FDA, as well as people from industry, as well as actually patients with the diagnosis of Parkinson's disease who are part of the group. And the reason I'm letting you know this is that one of the primary thing that we all came together last year to talk about was, did we think that pushing forward a biological definition of Parkinson's disease would be good for people who have Parkinson's disease? Would this help to bring better and more innovative therapies to patients faster? And that was 100% the motivation behind this entire effort. And the reason we needed to have all these people at the table was because everyone, all these different groups here, academic, industry, regulators, researchers, community partners, all of them play a role in bringing new therapies to patients, but we can only do it fast or as efficiently as possible if we work together and get out of our silos. And these groups honestly are oftentimes very siloed from one another. And so this was really an incredible effort of people coming from different areas and learning. I learned so much, honestly, going through this process about the FDA and regulations and things that I just, in my 25 years in medicine, I never knew. So this was a very collaborative effort. It's been a year from about the time of our first convening in October 2022 to this working group that happened in January 2023. We then put these concepts together with and put out this webinar in April to people who do research and clinical people who take care of patients with Parkinson's disease all around the world. In this webinar a little bit around a year ago, we then made a copy of the manuscript public for public comment for several months before we took all of those comments and all that feedback, back and submitted it for publication in June. And as Robin said, it was just accepted, or it was initially submitted in June, July, and then we finally had the acceptance in January, and it was published in February of this year, just this month. Okay, so what's the idea behind this? So this is the big picture of how we think about the entire course of Parkinson's disease. This vertical black line is where most people are diagnosed, which is the time when they start to have symptoms of slowness, stiffness, or tremor, which are the clinical definition, the current definition of Parkinson's disease. And then everything that happens to the right of this black line is where all of our clinical trials currently are, and how we think about Parkinson's disease. And this is actually where most of us as physicians who take care of people with Parkinson's disease, this is where we spend most of our time. We've been trying to push this as early as possible to try to understand the very first time somebody has symptoms of Parkinson's disease. But we know that by the time someone has slowness, stiffness, or tremor, a lot's already changed in the brain. And we learn that from our patients. They tell us, oh gosh, I've had sleep problems for years, or constipation for years, or loss of smell for years. And we think that those are associated with very, very early changes that, that are there before the slowness, stiffness, and tremor. And so we've been trying to push this earlier and earlier in understanding the entire range of what happens in the brain and body of someone who ultimately has the diagnosis of Parkinson's disease. And this is, again, the reference to the manuscript, and I want to just highlight two words here. One of them is toward, an integrated staging system. And the word towards was very specifically chosen because we very much view what I'm going to be showing you here as an initial first step. We wanted to take a first step and to get it out there into the public so that people could understand what we're doing and that they could apply their own data and their own thoughts and their own research to it. But it really is a first step. This is not a, hey, we've changed the game of Parkinson's disease and we've sort of we've finished this puzzle. We've done it. This is an initial first step. It's also right now just for research. This idea of a biological definition and staging is 100% to push research so that clinical trials can get therapies to patients faster. Now, if this does push therapies faster to patients, then it could potentially be applied to people in the clinical setting. But right now, it is not intended for clinical use. It's intended for research. And I'm going to talk a little bit more about kind of how we can live in this duality of these two worlds of this biological definition and traditional definitions all at the same time. So going back to what I said on the last slide, that Parkinsonism is defined right now clinically by by someone having this bradykinesia, this slowness, which is slow movement or low amplitude movement, plus either stiffness in the muscles or tremor. You don't need both, you just need one or the other of rigidity or tremor. One of the big challenges with this diagnosis, however, is that there are a bunch of things that cause this constellation of slowness, stiffness, and tremor. And as many people know who have the diagnosis of Parkinson's disease, is that there's a lot of other things that can also cause this that can be easily confused with Parkinson's disease. And they go by a bunch of other names with three-letter acronyms. There are medications that can cause a slowness, stiffness, and tremor. There are even some infections that can cause this. So the diagnosis is not straightforward. I don't see someone in clinic and see slowness, stiffness, and tremor and know immediately it's only Parkinson's disease. It could be a bunch of different things. And so how do we actually know it's Parkinson's disease? Well, right now, the only way we can do that is at brain autopsy, which I'm sure you've heard Robin talk about why it's so important to get brain autopsy if it's possible after someone passes away, because that's the only way right now to 100% say someone has Parkinson's disease. So what do we look for? So this is a little cartoon of the brain, and this black line here is the area of the brain where most of the dopamine containing neurons are made. And dopamine is actually made out of a substance that contains neuromelanin, which has a pigment in it. And that pigment causes this section to be black, and so it's called the substantia nigra, or black substance. And this is where most of the dopamine containing neurons in the brain are. And they send their dopamine up to this part of the brain in the caudate and putamen. So once someone passes away, if they donate their brain to research, someone who does not have Parkinson's disease, you can visibly see this black stripe. Actually, just with your own eyes, you don't have to look through a microscope. In someone who has Parkinson's disease, you see this paleness of that black stripe, and under the microscope, in someone who does not have Parkinson's disease, you see all of these neurons. Every one of these dark dots here, this is a neuron containing that's a dopamine producing neuron. And then here in the person with Parkinson's disease, you only see a couple of them here. And so this is the loss of those dopamine neurons under the microscope. And then when you look at high power, you see that those neurons that are still surviving have these pink blobs in them, which were in 2012 first viewed under the microscope by Dr. Lewy, and he called them Lewy bodies. These are some of his original drawings from over 100 years ago. And then in 1998, it was identified that these little blobs contained the protein alpha-synuclein. Alpha-synuclein is a protein we all have in our brain. It's a very important protein. It helps nerves communicate with one another. For some reason, and we still don't understand why, when people have Parkinson's disease, we identify that these alpha-synuclein containing Lewy bodies are in the brain. Now, we actually don't know if the Lewy bodies cause the neurons to die or if they're just a byproduct of some other process going on. We just know that the presence of these alpha-synuclein containing Lewy bodies right now is how we identify that someone had Parkinson's disease during their life. And in fact, we look in different regions of the brain and identify the majority of them oftentimes in these motor systems, but we can see these Lewy bodies throughout different parts of the brain. Okay, so this was all very sciencey and technical, but it was important because this is right now the state of the art for diagnosis is at autopsy, but we need to be able to do this earlier in people who are living with Parkinson's disease. And so, in fact, and this is actually a picture that has both Dr. Lewy and Dr. Alzheimer in it. They worked together, 1912, when the Lewy bodies were first described. This is another picture of them. And so these deposits of alpha-synuclein are found both in people with Parkinson's disease and in people with dementia with Lewy bodies. And the point I want to make here is that the pathologists at the time of autopsy can't tell the difference between someone who had Parkinson's disease and someone who had dementia with Lewy bodies. The brain looks basically identical visually with regard to these Lewy bodies in people who had Parkinson's disease and people who had dementia with Lewy bodies. So from a pathology perspective, these are identical diseases. Now, why some people start off with the motor symptoms, which is what we call Parkinson's disease, and some people start off with thinking and memory problems, which we call dementia with Lewy bodies, we don't know the answer to that question. But at the end of life, the brain looks very similar. Okay, so getting back to this picture then, so since I can't tell right now whether someone has clinical Parkinsonism if, they have those Lewy bodies in their brain or not, right now, I can only tell at autopsy that somebody has these Lewy bodies. And so in Parkinson's disease, in living people, we can just look at this brain scan, which shows the loss of dopamine. But I can't tell if that loss of dopamine is from Lewy bodies or not, because that loss of dopamine could be from another disease like multiple system atrophy, which also has abnormalities in alpha-synuclein, but does not have Lewy bodies. It has these other little glial cytoplasmic inclusions, or other proteins like tau can also cause loss of dopamine. So this dopamine scan, which we oftentimes do, unfortunately can't tell the difference between Lewy body associated loss of dopamine or glial cytoplasmic inclusion associated loss of dopamine or tau associated loss of dopamine, right? Because you have loss of dopamine in all these different conditions and you have Parkinsonism in all these different conditions. But up until now, we couldn't differentiate between the protein that was associated with that change. And so we could see the end result of what was happening in the brain, but we couldn't see or couldn't identify what was happening in the brain at a molecular level. Okay, so that's the big change, is what's the status of assessing alpha-synuclein pathology in living people? Well, this has been a struggle for years. People have been measuring alpha-synuclein in the blood and in the cerebral spinal fluid of people with Parkinson's for a very long time. And traditional lab tests, we call those ELISA-based assays, were really bad. They just had a lot of noise to them. They just didn't work very well. And there's a new biomarker, though, that has addressed these limitations and can finally detect whether someone who is alive has this the alpha-synuclein that's associated with these Lewy bodies. So right now, this can only be done with a lumbar puncture. So most of you know what a lumbar puncture spinal tap is, but I'll just quickly go over it. And for those of you who don't, so this is a little cartoon. Basically, in the small of your back, you can sort of see the little cartoon picture here at the spine. The very, very small of the back, right at the hip bone level, there's a little space in there between your lumbar vertebrae where there's no spinal cord. It's actually, the spinal cord is above this level, and there's just a sac of fluid sitting there. And it's actually quite straightforward to put a needle between those vertebral levels and get some fluid out. And that cerebral spinal fluid is the fluid that bathes the brain. And it sort of buffers the brain not only from injury, but it's also a source of nutrition for the brain, and where different proteins are constantly being exchanged. We can test the glucose or sugar levels in the brain through cerebral spinal fluid. We can look for proteins. And it basically gives, it's like a biopsy for the brain, but you're just using the fluid. It's the same, similar to getting a blood test for the body. It's that kind of idea. And so we've been collecting cerebral spinal fluid for many, many years in people with Parkinson's disease. Some of you might have even been part of some of our research studies here at Stanford doing this, or some other studies. And we've been trying to find a way to use the cerebral spinal fluid to identify these proteins associated with Parkinson's disease for over a decade. And some folks have figured it out. And so this is what the assay is, just so you all know what we're actually talking about. It goes by a couple of different names, which makes things very confusing. Some people call it the seed amplification assay. Some people call it RT-Quick. Some people call it PMCA. I'm hoping that like one name will stick and everyone will just use it, but right now it's got a couple different names. So the way it works is that you have this tube of cerebral spinal fluid, and you're asking this question: does this CSF have the type of alpha-synuclein that is clumps together? So we call that oligomers, so the clumping type of alpha-synuclein. So they put these seeds of alpha-synuclein in the CSF along with a little fluorescence, and they put it in these different wells, and they go through this cyclic process of shaking it to try to get it to grow together, and then they fragment it and elongate it, and it sort of goes through the cyclic process. And if the cerebral spinal fluid contained the clumping type of alpha-synuclein, then it grows these long fibrils that have all of these different fluorescence on it. And then you put it into a fluorescence reader. And if you get that fluorescence amplification, then that means that the clumping type of alpha-synuclein was detected. If you don't get amplification and it's just this flat line, then that means the original cerebral spinal fluid sample did not have that type of clumping alpha-synuclein in it, and it was not detected. So it's a yes, no answer. Okay, and that's important. And again, it's a yes, no answer. All it says, it's very simple. All it says is that we believe that the cerebral spinal fluid shows a signal that means that this person will have these Lewy bodies in their brain. That's it. It's a yes, no, that we think that this person will have these Lewy bodies in their brain. We do not. Detected, not detected. It's just a biomarker reflecting what up until now we could only identify on a microscope at autopsy.
Can I just ask a clarification?
Yes, please.
Uh,
Yep.
that this is a yes or no answer as to whether Lewy bodies are present in the brain or whether alpha-synuclein is present in the brain.
Correct. That's good clarification, Robin. So it's a biomarker that Lewy bodies are detected in the brain because all of us have alpha-synuclein in the brain, and so it's the specific kind of alpha-synuclein that forms that you would find in Lewy bodies. So specific to Lewy body type of clumping alpha-synuclein. Yeah, so specific to Lewy bodies. Thank you. It does differentiate the type of alpha-synuclein that I mentioned in multiple system atrophy. This is a graph here in panel A that shows that people with Parkinson's disease get a higher amplification, whereas people with multiple system atrophy, it's a medium amplification, and people who don't have either of these, it doesn't amplify at all. So we believe that this can differentiate between the type of alpha-synuclein that clumps in Lewy bodies versus the type of alpha-synuclein that clumps in people with MSA. More research needs to be done to validate this, but this is one study in 2020 that did show that. But multiple studies have been shown that between people with Parkinson's disease and people who don't have Parkinson's disease, the accuracy of this test is somewhere around 95, 98%, which is extraordinarily high actually for a biomarker test. Now, I say for now because clearly cerebral spinal fluid is not an ideal way of doing a test. That there is an enormous amount of effort being done to get this test in more accessible fluids. But right now, that's where the most validation is. I'm going to talk a little bit more about what's next. What are we trying to do to get it more accessible? But right now, it seems to only be truly validated in cerebral spinal fluid. But that hopefully will change in the near future. In addition, we do still like to pair that with the dopaminergic changes that we see on the DAT scan, because it seems like people who have the positive alpha-synuclein Lewy body test and have dopamine changes on their brain scan, that combination is associated with having the slowness, stiffness, and tremor. And that's where the staging part of this comes in, of having two different biomarkers, because there are some people who might just have the alpha-synuclein but not the changes in dopamine. And we're still trying to understand what that means. As I said, this is a very early stage, or very early part in our research, trying to understand all of this. So for now, again, dopamine imaging with DAT imaging is our best way of looking at dopamine function, but there's actually a lot of work done trying to get better markers of maybe even blood markers to identify dopamine function in the brain. So we've put together this writing group, this idea of a biological definition. And we named it neuronal synuclein disease because it made it a lot more precise to say that we're not talking about necessarily people who have slowness, stiffness, or tremor, or people who have memory changes that are associated with Parkinson's that we call dementia with Lewy bodies. We're just thinking about this from the biological perspective. And that's because we wanted to be able to fill out that entire range of symptoms, all the way from constipation and loss of smell through when people might have motor changes or thinking changes, through the whole range. And so independent of what kind of symptoms they had, whether they're the Parkinson's kinds of symptoms or the memory kinds of symptoms, or those super early symptoms like constipation and smell loss, we wanted this to include all of that and have a biological definition that's independent of any clinical symptoms. And so we took a very biologic name, neuronal synuclein disease. That also made it easy for us to differentiate between when we're talking about someone with clinical Parkinson's disease, which we all talk about now, and in research when we're defining a group of people based just on their biology and not based on their symptoms. And the idea here, again, is that we simply could take what we used to only be able to do at autopsy and say with some level of certainty now that this person if they were to pass away right now and we had a slab of their brain to look at underneath a microscope, we believe we would see Lewy bodies there. So that's all this does. It just allows us to identify in life what we used to only be able to say definitively was there at autopsy, which is a big change. So how does this terminology integrate with our current Parkinson's disease and dementia with Lewy body clinical diagnosis? Well, as I said, we diagnose Parkinson's disease based on bradykinesia plus tremor or rigidity. And similarly, the clinical diagnosis of dementia with Lewy bodies is made by someone having dementia plus a couple of these other symptoms: Parkinsonism, hallucinations, REM sleep behavior disorder, or cognitive changes. But there's so much overlap between these two clinical disorders, because we know people with Parkinson's disease can also have REM sleep behavior disorder. They can also have some mild to moderate memory changes. They can also have hallucinations. There's a lot of overlap clinically between these different disorders. And this has actually caused an enormous amount of challenge in the field because the overlap is so tremendous. There's probably not a month in clinic that goes by that someone doesn't say to me, well, I used to have the diagnosis of Parkinson's disease, but I look at all of the symptoms that someone with dementia with Lewy body has, and I have those too. So do I have both diseases? But as I mentioned, the pathologists just call the whole thing one thing because of it all looking the same under the microscope. So we still have to figure out some of these differences and these overlaps. But the idea is to go from what we currently have. This is actually the long, full diagnostic criteria for Parkinson's disease, and this is the full criteria for dementia with Lewy bodies. But in fact, what these criteria really are is this overlap between motor symptoms, what we call neuropsychiatric symptoms such as anxiety, depression, cognitive symptoms, sleep symptoms, autonomic symptoms. Those are blood pressure changes and cold and heat changes that people will sometimes have in their body, sensory changes. All of these things exist across what we currently call Parkinson's disease, dementia with Lewy bodies. Sometimes you'll see the word Lewy body disease or Lewy body dementia, Parkinson's disease dementia, and then we have these other names called prodromal Parkinson's disease or prodromal DLB, which is what we call people who have some other symptoms, but not quite Parkinson's yet. This really just unifies all of these if you have the biology under one term. Because right now, the difference between dementia with Lewy bodies and Parkinson's disease is just a matter of time of which came first. If the motor symptoms came first, we clinically call it Parkinson's disease. If the cognition and memory problems came first, we clinically call it dementia with Lewy bodies. But this allows us to think more broadly about what's the biology underlying two things that clinically look very different from each other. So most people with clinical symptoms or in clinical research will not have the biomarker data to determine if the cause of their symptoms is from this neuronal synuclein disease or not. And that's fine. And for now, the designation of whether someone does or does not have this will not change how people with a clinical diagnosis of Parkinson's disease or dementia with Lewy bodies are treated therapeutically. And we do not believe there's enough data to support using this terminology or the staging system in clinic. Right now, we need to figure out how to use it in research first so we can get all of the kinks and knots and challenges worked out before we roll this out to clinical use. And so using clinical definitions is most appropriate in most patients. And we are not in any way advocating for the abandonment of the word Parkinson's disease. And the coexistence of these terms, neuronal synuclein disease and the clinical diagnosis, should be used in contextually appropriate ways, depending on whether someone's in a clinical trial or if they're being seen in clinic. And so these terms are just going to coexist for a while as we're figuring out how well we can accurately identify people. And quite frankly, until we have a way of doing this test that's a lot easier and a lot less expensive. Until it's a test that we can do in blood, this is a research only type of thing, because it's just too hard and too expensive to do on people, and it's just not possible. So I wanted to take another step as to why it's important that we do more testing on this biomarker. So when we think of a biomarker or biological marker, we basically get this test positive, test negative, or detected, not detected. The reality is on the top here, whether the person actually has the disease or they don't have the disease. When the biomarker says positive and in reality someone has the disease, we call that a true positive. If the biomarker is detected, but the person does not have the disease, we call that a false positive. When the biomarker does not detect the disease, but they have it, we call that a false negative. And when the test is negative and the person does not have Parkinson's, we call that a true negative. Now, these are terms a lot of people have heard over the last 5 years during COVID. And in fact, I relay the synuclein yes, no, detected, not detected, very similar to the COVID antigen test that I'm sure we've all taken, at least I've taken like hundreds of times over the last couple of years, where you get a yes, no, right? It tells you either yes, you have the antigen associated with COVID, or no, your cold symptoms are not associated with COVID. And for the most part, those match up. But occasionally there's a mismatch. And in fact, the first time I got COVID a couple winters ago, the first test I took was I had a little bit of a cough and a little bit of a runny nose. And the first test I took was negative. And then the next day I took another one and it was positive, and then it was positive from there on out. And so that first one that I took, that was a false negative, because my symptoms or the amount of antigen in my body must have been too low for the test to detect it. And that happens. And that's the kind of thing that we have to figure out with this test, is how often are we getting false negatives and false positives? It's a really, really important part of a test. And it's there with every single biomarker test. You always have some false positives and false negatives. The question is, how often does it happen? And what do you do to make sure you don't get those, that that the test means what you think it means? So I hope that helped to clarify why this isn't just like roll it out today and give it to everybody. We have a lot more work to do to understand exactly how this test works before we start really thinking about using it broadly in clinic.
And how can we, if you could go back to that
Yep.
previous slide,
Yes.
how can we, you said we need to uh, understand how often we're getting false positives
Mhm.
and false
Yep.
negatives. Do we still rely on brain donation then to help us with that, or how are we going to test?
100%.
Okay.
100%, absolutely. So we in fact, I while I was traveling this week, just got sent the data from the Michael J. Fox Foundation PPMI study of the little over 20 individuals who have come to autopsy in that cohort. Most of them, we have their cerebral spinal fluid, and we've gotten it tested for the biomarker. And we're going through right now, and I have some of the early results of that here, as to how oftentimes there's a match, meaning, either test negative, autopsy, yes, Parkinson's, or the match being biomarker negative, autopsy, no, not Parkinson's. So how often there's a match and how often there's a mismatch. So we absolutely need to do a lot of verification and validation, and autopsy studies are the absolute, that's the gold standard. That's the way we're going to know for sure how often we're wrong and how often we're right. So we're going back in our records and finding anyone who in the past gave CSF and has now donated their brain, as many matches as we have to look at those. That's actually really going to help us tremendously to figure this out as quickly as possible. Thank you for that clarification. Okay, so we have this biologic definition basically of being synuclein seed amplification detected, so Lewy body detected on this biomarker, plus in some cases people having that dopamine positive imaging as well. How does this help? Why did I spend 2023 going to a million meetings and 7 a.m. calls trying to get this forward? Well, we believe that this provides a framework to allow therapeutic development to happen across the entire continuum of people with neuronal synuclein disease, all the way from the earliest stages through the most advanced stages. It allows for selection of people with biologically defined disease to enroll in clinical trials. So there are some clinical trials, for instance, that are out there right now that directly target that clumping alpha-synuclein. And there's been a couple of those studies that have already happened, and in retrospect, probably about anywhere from 5 to 10% of people that might have been in those studies were not positive on this test. And so that adds a lot of noise to the clinical trial. So this will help clinical trials at all stages of Parkinson's have a better sense of whether the people in that study really do have Lewy body disease or not. That's very important. It will also allow us to have these stage-dependent selections of endpoints for clinical trials. So, as I think a lot of you know, the current way that we look to see whether a clinical trial was successful was whether or not the motor exam improves. And that's the test where you do the tapping and hand open, close, and palm open, down, and tap the toes and walk up and down the hallway. And as everybody knows, that's not very specific because there's a lot of different things that could influence how someone does on that test. If they had a good night's sleep, if they, had a good meal the day before, or if they're still recovering from, a cold or a flu, their test might not be as good. Or if they got into an argument on the car ride over to the clinic with, their spouse in the car about directions, they might have a worse exam. So many things influence that exam that are not directly related to whether or not the drug that someone's taking is helpful or not. And so we're hoping that this is the first step for a biological basis of endpoints in clinical trials, so we can actually look at levels of proteins or levels of other things. And so this is as I said, a first step, but it's an important first step to try to get us more to the biology of what's happening in the brain and targeting that.
Could
So,
you
yeah.
could you just explain what an endpoint is?
Yeah, so in order for something to get approved, a drug to get approved for the FDA, it has to have a single thing that it helps, and you can only have one from a statistics perspective. So that's the endpoint of a study. So, for instance, the clinical trial that got the first dopamine agonists approved, Mirapex, Referral, and such, looked at the change in, again, that movement disorder, that MDS-UPDRS motor exam from the beginning of the trial to the end of the trial. So did we see improvement on that test in the people who were taking the drug versus those who were in the placebo group who were just taking the sugar pill? And from a statistics perspective, you can only have one endpoint, and you have to say that what your endpoint is before the trial starts, and you have to meet that endpoint. And if you don't meet it, then the trial fails. So whenever you see the headlines of a study failed, that usually means that they did not show that the treatment was better than a placebo in improving whatever endpoint they had predetermined at the beginning. And the FDA is directly involved in choosing those endpoints. So usually they say before the trial starts that they will accept the terms of that endpoint when considering approving a drug. So there's actually an involved process. You can't just pick anything, and if you get it, then boom, your drug's accepted. You have to have gone through a very rigorous vetting process that endpoint is considered meaningful and is clinically significant as well as statistically significant. So it's quite a rigorous process to get an endpoint approved to bring a drug to FDA approval. I've learned a lot about this in the last year. I could go on forever about it. It's quite a fascinating process. Okay, so I'm not going to spend much time on this, but I just did want to say that we have put together, again, a conceptual model of a staging system of stage 0 through stage 6. Again, this is a conceptual model. We are still working out a lot of the details here, and trying to biologically anchor each of these. But this is, you'll hear about the staging system. This is just a proposed model. It's very early. Do not go asking your doctor, what biological stage am I in? We are just starting to figure this stuff out. We've got a lot more work to do here. Okay, so I'm going to show you just a little bit of data to support this. This is data from the Parkinson's Progression Marker Initiative, which is the sponsored study from the Michael J. Fox Foundation. This included over 700 people with a clinical diagnosis of newly diagnosed Parkinson's disease, a bunch of people who were healthy older adults, and about 300 people who had risk factors for Parkinson's disease, which we called prodromal. They had motor assessments, memory assessments, those brain scans, as well as cerebral spinal fluid collected. And again, a handful of them have since passed away and have given their brain for autopsy donation and postmortem tissue. Okay, so just super quick here, I'm going to orient you to this. So basically, these are the newly diagnosed individuals with Parkinson's disease, and the vertical line here is actually a line that everything below that is abnormal smell. And the horizontal line, everything below that is low dopamine. And that's kind of how we used to determine whether, whether or not we thought people had Parkinson's disease was based on the dopamine imaging. The people who had the filled in circles, their cerebral spinal fluid showed a positive, meaning that it was detected, and the people with the open circles, they had theirs was negative. It was not detected. And so as you can see, almost the majority of the people, this is over 500 people here, had a detected synuclein amplification assay test, that Lewy body test on their cerebral spinal fluid. What we don't know yet is if these open circles are true negatives or false negatives, right? So did these people really not have Lewy body disease, which would be a true negative, or was the test just not sensitive enough to pick it up in those people, which would be a false negative? Like my first COVID test was a false negative. Is that what we're seeing here? We don't know yet. We have a little bit of data following up these people, but we are looking into it very aggressively to answer that question. But I will just flat out say right now, in most of them, I do not know the answer to that question yet. So again, this was actually over 1,100 samples of individuals. It was incredibly accurate. 93% of those individuals who had a diagnosis of Parkinson's disease had an abnormal test, and it was less than 5% of people without Parkinson's disease, actually, it was abnormal. And again, the question there is, will those individuals eventually develop Parkinson's disease or not? We are still figuring that out as well. What was very interesting is that in those individuals who had no motor symptoms yet, but were super high risk for Parkinson's disease, so people who had loss of smell or that sleep disorder, actually a good number of them were also positive. And that tells us that this biomarker probably becomes positive before people develop their first slowness, stiffness, or tremor. Now, I cannot say 100% that that is always the case, but in a good number of individuals, we are seeing that. And as we follow these people longer and longer, it seems like having a positive test is one way of anticipating which of these people will most likely develop the symptoms of Parkinson's disease. But what I don't know is what time frame that's in. Is that in the next 1 year? Is that the next 5 years? Is that the next 10 years? We just don't know. So we are not recommending people go out and get this test, because even if it's positive, and that means they will get Parkinson's disease, I don't know what time frame, and so it's not useful outside of the research setting.
And what does it mean on that slide, previously called prodromal?
We're trying to get away from that term prodromal, mainly because let's say we had a therapy that I could give to someone who had loss of smell and a synuclein positive test, and it would prevent them from developing slowness, stiffness, and tremor. That's what we eventually want, right? I want to prevent people at risk from ever getting Parkinson's disease. the term prodromal is problematic for the FDA because it's not a disease name, it's you have a prodrome to something. And so we're trying to get away from that name for regulatory purposes. Yeah, sorry, it's a lot of lingo. I apologize for that.
That's
But
okay. You
that's
said
yeah.
prodromal in a couple previous slides, so I thought, okay, what does this mean?
Yeah, it's the term that's the term that's been used for the last 5 or 10 years about people who either just have loss of smell or have REM sleep behavior disorder or have constipation or have a genetic risk for Parkinson's disease, but they don't have any slowness, stiffness, or tremor. They're considered that pre-motor phase or at-risk phase. There's a lot of words that have been used. Prodromal's been the most recent one, but again, from a regulatory perspective, it's not a good word to use, and so we're trying to get away from that. Officially in the PPMI study, this group of individuals were labeled the prodromal PD group. So if you look on the website, that's what it says, but we're again trying to get away from that word. It was not the best word to use. Okay, so in a small group of people, we found that this test accurately predicted what we found at autopsy. So we've had 19 people who passed away and donated their brain. There's actually been a few more, but I haven't had a chance to look at the results yet. And all 19 had confirmed accuracy with the test. So 17 of them were SAA positive, so synuclein seed amplification positive for Lewy body in CSF at the time of their diagnosis. And then many years later, when they passed away, they were confirmed to have Lewy body pathology at autopsy. There were 2 individuals who were actually SA negative, so not detected in their CSF at the time that they were diagnosed with Parkinson's disease, and neither of them had alpha-synuclein Lewy body pathology at autopsy. One of them had multiple system atrophy, actually, that other diagnosis that I mentioned. The other one was a little more complicated. And so out of 19 people, it's 100% match, but that is really, really low. And I want to say this with extreme caution. I never believe numbers that are double digit in research, unless I've got triple digit numbers. You really, there's just a lot of room for error when you have small groups of individuals. And so I remain cautiously optimistic, and we need a lot more data for me to feel convinced of the data for sure. Okay, so can this test only be done in cerebral spinal fluid? So right now, yes, but as I said, we're really trying hard to do other things. So in fact, in people with Parkinson's disease, alpha-synuclein can be found in other parts of the body. There was a study in 2013 that showed actually in your salivary glands, you could find some in the olfactory bulb, in the appendix or on colon biopsies, even in the skin, but the sensitivity and specificity of these are pretty low. The skin biopsy is looking like one of the most promising one, which is actually very easy to do a skin biopsy. But the concordance between the CSF and the skin has not been 100%, but they're still working on that, and it's getting better and better and better. So I'd say skin is probably the closest one to, I think, getting a really good assay, but ultimately blood is what we're trying to do. So it's just a blood draw, like, any other blood draw, like getting your cholesterol checked or anything like that. Again, this is sort of the accuracy of looking at these different areas. A lot of work going into trying to find something. Saliva, someone's studying saliva, someone's studying tears. We're trying a lot of different stuff to try to find something that is easier than cerebral spinal fluid. So believe me, I don't want to do any more lumbar punctures either. They're a lot of work and people don't like them. So I really hope we can find something that's a bit easier. So should you get this test done? No. So this is meant for research right now. And for someone who already has the diagnosis of Parkinson's disease, the information from the test will not change anything about your current treatment or care. Because if the test is negative, I don't know if it's a true negative or not. And if you have all the signs and symptoms of Parkinson's disease and your doctor's very confident in your disease, then I would not necessarily get additional information because I trust my clinical diagnosis right now better than I trust the test. Okay, And again, while the results from the skin biopsy look promising, I would only use this for research right now. And I would just also add that these are very expensive tests, like $1,000 for the test, which is not something that, again, if I don't trust the test, I certainly wouldn't pay $1,000 for it. So why is it such a big deal? Mostly because it is really energizing big pharma and startups to get a lot more interest in Parkinson's disease. I mean, I've had more conversations with different pharmaceutical companies about interest in Parkinson's clinical trials in the last year than, I have in the last 10 years, which is really exciting. Pharmaceutical companies can be more confident that the people they enroll will actually have the underlying biology that is targeted in their drug, so they're very excited about it. So this is a great thing for us trying to do everything we can to push for better, more specific, and hopefully disease-targeted drugs in the future. So if you had the test and it was negative, what would that mean? So as I said, it could be wrong. It could be a false negative, and we just need to figure out how often that's happening. It's also, there also are some kinds of Parkinson's that are not caused by neuronal synuclein or Lewy bodies. And this is particularly true in individuals who have a certain kind of genetic mutation, this LRRK2 genetic mutation. About a third of them don't actually have Lewy bodies. And that was true at that one other autopsy case that I mentioned in the PPMI study. That individual had LRRK2 mutation, and they had loss of those dopamine neurons in their brain, but no Lewy bodies. So it's sort of a non-Lewy body version of Parkinson's. Very, very rare, less than 1% actually of all people with Parkinson's disease. But we don't know yet. We need to still figure this out, and that's why this is all still in research. Should at-risk people or family members get this test done? No. So even though it's been well validated in people with Parkinson's, we have not done enough work in people who don't have symptoms. Again, I showed you data from like 30 people on that one slide. I want triple digits, and we don't really know what it means if someone who has no symptoms has a positive test. And even if it was a true positive, I don't know when that means. Would they get Parkinson's in 5 years, 10 years, 20 years, 50 years? We just don't know. And that's important information to have whenever you do a test. So I'll just finish up by, again, as I always do, encouraging folks to consider participating in research. We literally could not have done this if thousands of wonderful patients over the last 15 years had not volunteered to do a lumbar puncture for research and let us collect their clinical information. This was truly the work of hundreds of researchers, but thousands and thousands of patients. And it is 100% because of patient participation that any of this work has happened, but it will require patient and participation in the future for us to do even better, which we have to do better. Of course, the Stanford Healthy Brain Aging Study is still recruiting individuals. The PPMI study is also still recruiting, although I hear that they're going to be probably finishing up their recruitment in the next year. This is for newly diagnosed individuals with Parkinson's disease or those at risk. And then I just wanted to give a really quick shout out for anyone who hasn't been part of our microbiome study. This is a super easy study to do that looks at stool samples of people with Parkinson's disease and their someone in their family who lives in their household that we're also recruiting for. We have many other studies we're recruiting for. I'm going to send my slides to Robin, and I'll actually include the flyers from all the studies we're recruiting for at Stanford. We'd love anyone to be involved. This is another place to go to be up to date for any of the clinical trials, either at Stanford or at UCSF. And I just want to conclude by saying that this biological definition really has the transformational ability to measure who has the biology of Parkinson's disease or dementia with Lewy bodies in living people. The data are very strong and supported by data. The adoption, I hope, will eventually allow us to really push clinical trials forward, but this will evolve. This is our first pass at this. And I have said this at every single talk. If this is still the version of this that we're using in 5 years, then I have not done my job. My research colleagues have not done their job. The NIH and the Michael J. Fox Foundation have not done their job. This is a first pass. We wanted to get it out there so that we can start working on it and revising it and improving it as quickly and as data driven as possible. So thank you all so much for your time, your attention. This is my wonderful research lab and my funding sources. And with that, I will stop sharing.
Okay, great. Thanks very much, Dr. Poston. If people have questions, please type them into the chat or the Q&A box. Either one will work, and we'll start looking at those. But I will start off with a few questions
Yes.
that I had in mind. What are the parallels here to the Alzheimer's research community? It always seems to me like the Alzheimer's folks are a little further ahead than the Parkinson's folks, and we're kind of always catching up. But maybe they have great models that we can rely on.
Yes, we really learned a lot from the Alzheimer's community, and I'll say several members of them were at our initial kickoff meeting, that one in January, including Cliff Jack, who's been one of the real leaders in the Alzheimer's field of a biological definition. You are correct. They're about 15 years on the jump on us with biological discoveries. So they had the first test of amyloid positivity. Again, over 15 years ago from the cerebral spinal fluid. That's since become something that is commercially available. They also have brain scans that can look for the abnormal proteins involved in Alzheimer's, the amyloid and the tau that are FDA approved, which we do not have a synuclein brain scan yet. That's also very much in the works and would be very helpful for us to understand. And they now do have a blood-based biomarker as well for Alzheimer's. But we get the advantage of learning from all their mistakes and honestly, the technology that's gotten pushed forward by a lot of the money that's gone into the Alzheimer's field. I think ultimately, though, where these areas will most benefit is that we know that actually about 10% of people with the diagnosis of Alzheimer's disease either have Lewy body in their brain or they have both Alzheimer's and Lewy body in their brain. And we know some people with Parkinson's disease have both Lewy body and Alzheimer's in their brain. And our ability to identify the full profile of proteins that are impacting someone's symptoms will ultimately allow, again, these targeted therapies. So, I mean, I can imagine, my hope one day is that, someone has a symptom and they go in to see their doctor, they get a blood draw and they profile it for amyloid and tau and Lewy body and other proteins, and then they prescribe specific therapies for each one of those that they have or don't have that's associated with their symptoms, right? That's my 5 to 10-year vision of where this is going. And that's also, I'd say, the vision of everyone on the writing team for this is that we have specific therapies that target each one of these. And that's where the Alzheimer's and the Parkinson's field in many ways will converge, because anyone who has that, who you can test one protein, you can test them all, ideally.
Right. Okay, we have a question from the audience, which is, can CSF samples be preserved, frozen, so that they can be used later on for research months or years later?
That's a great question. It depends a little bit on the research that's being done. There's a little bit of research that does require fresh cerebral spinal fluid, but the majority of it, if properly preserved and frozen, can stay frozen for 1 to 2 decades. And in fact, the data that I just showed you from the Parkinson's Progression Marker Initiative, that cerebral spinal fluid was all collected between 2009 and 2014. And it's been sitting in freezers being used for a bunch of different studies. But the moment we had this potential biomarker, we were able to send over 1,000 samples to get it tested within 6 months. Same at Stanford. I've been collecting cerebrospinal fluid since 2010 in research participants. We have similarly been able to get over 500 samples that have been sitting in freezers, wonderful patients who have volunteered and gotten almost all of them tested for research. And so, for the most part, as long as it's done properly and it's stored properly, for the most part, we can still use it for research.
Okay, great. Another question from the audience, which is in the study where 19 people passed away and donated their brains for autopsy, how long did that study run? And how long between when they were tested and when they were autopsied?
It's a great question. So that's again that study that started in 2009, and those were all the folks who had passed away through, I believe, 2020. So about 11 years. But not all of them. Some of them had passed away much, much earlier, like 2014. So I think the smallest amount of time was 4 years, and the longest amount of time was about 9 years. So it was in that range. I would need to look at my notes to have the exact numbers, but based on memory, that was about the range between the two.
Okay. And let's see, as an aside, until there is a cure, what is the best way to keep remaining brain cells in the substantia nigra alive?
Exercise. So we don't have proof of this in living humans, but in animal research, there is something about exercise that helps the dopamine neurons in the substantia nigra resist or be resilient to damage, even when they are faced with different toxins. And so we do believe that exercise is very healthy for the substantia nigra neurons. And so that is the number one thing you can do. And whatever level of exercise you can do, whether it's doing weights while sitting in a chair or walking or doing an exercise bike, whatever it is, it's a good thing. So whatever works for you, please exercise.
Okay. Eventually, long from now, when all of this research is done, do you think that the terms Parkinson's disease and dementia with Lewy bodies will go away?
I'm not sure. It really depends. Terminology has a funny way of sticking around in the medical field. We have seen other na and other diseases that were named after humans, and that's kind of not the vogue anymore. We try to name things after the biology and not the person. It's a bit of an old-fashioned thing, but there are some things that have stuck around for traditional reasons. So I'm not sure, and honestly, what I care about is that we are able to call things something that works the best for patients and families. And if they feel more comfortable with the term Parkinson's disease than neuronal synuclein disease, then I'm pretty darn happy with that.
Yeah, I don't
So,
think neuronal
whatever works.
synuclein, yeah, neuronal synuclein disease doesn't really roll off the tongue.
Just throwing off the tongue super easy. Yeah, yeah, I recognize that. And so it just for me it really depends on what works best.
Yeah.
I'm a very pragmatic person. It's about what's going to get therapies to patients the fastest and how we can communicate those therapies to patients as easily as possible.
Indeed. Um, Speaking of kind of clinging to things, clinging to the
Yeah,
past, this proposal addresses researchers
yeah.
and of course we're a lay audience listening to a talk about this today. What it seems between the lay audience and the researchers are clinicians. What has the response been from clinicians to this proposal?
It's a great question. And it's something that I had the opportunity at our big International Movement Disorder Society meeting. This is a meeting. It was in Copenhagen. It's very international. It's all the movement disorder specialists across the world. And I had a chance to actually give a version of this talk to that group. And that was the first time a lot of clinicians had heard the proposal before. And most of them, the response was, this is really exciting, and I hope that this helps us get a better therapy for our patients. But a lot of them had a lot of questions too. What does this, should I be getting this test for my patients? What does it mean if I live in a country where you can't get this test? my patients can't afford $1,000 cerebral spinal fluid test. Are you saying I have to do that? And so I think there's a lot of practical and pragmatic, again, issues that really very seriously need to be addressed with this. But overall, I'd say most clinicians, if it's something that's going to help them get a better therapy eventually for their patients, that's a very exciting thing. But this has moved very, very quickly, and there's probably a lot of movement disorder specialists who haven't heard of it because you either had to be at the talk in Copenhagen, which was again not easy to get to, or the paper was just published 3 weeks ago. So this is very new. Like, you guys
Yeah.
have heard this probably sooner than a lot of movement disorder specialists out there. So please be patient with our field. I am giving as many talks as I humanly can in the next 6 months to try to communicate this to as many doctors as possible. But it's just going to take a little bit of time for us to educate people on something new. Change can be hard, and I really appreciate that. And quite frankly, what everyone is saying is, this is an exciting idea. Show me the data that validates it. And that is a very appropriate and scientifically accurate response. And
Hmm.
I will also be spending the next year working with my colleagues to try to really, pressure test this entire idea with data, as much data and the best data as we possibly can.
Hmm. Okay. If anybody has questions, please type them into the chat or the Q&A. I have a one or two more.
Okay.
You mentioned, I think I might have misunderstood. So right now we have a DAT scan that uh, talks about dopamine dysfunction in the brain. And if a DAT scan is comes back as being abnormal, we don't know if it's Parkinson's disease or MSA or PSP or any of these other diseases. Um, I think you said that we're working on a blood test
Mhm.
to identify dopamine dysfunction. Did I hear that correctly?
You did, you did.
Okay.
Um,
All right.
so so we and others have been working on this for a couple of years, that there does appear to be a test in the we first identified it in the cerebral spinal fluid. There does maybe seem to be some signal in blood of a abnormality in dopamine processing that seems to be related to dopamine loss. It's very, very new. We have reported on it. Two other labs have reported on it. Three now, actually, three other labs have now reported on it. Very new, but it would be very promising if we
Oh.
could potentially, again, anything that could be done in a blood test that could just be part of routine care. You get your cholesterol tested, you get your thyroid tested, you get your proteins tested, you get your dopamine tested, that kind of thing that could be done in a single blood draw would be wonderful, but we're in very, very early phases of that.
Okay. And I thought that one of the skin biopsy, I don't know if biopsy is the right word, but one of the
Yeah.
skin tests for alpha-synuclein or Lewy body was available over the counter.
Yeah, so there is one that is
The
available
same
to be
one,
done
I think. Hmm.
clinically.
Hmm.
The data to it's not exactly the seed amplification assay. It's
Okay.
looking under a microscope and looking at whether synuclein is present in the nerves or not. So
Hmm.
it's a little bit more manually requiring, and that's a very well-trained person has to look under a microscope and look at it. So it's not like it goes through an assay test. It is looking very promising. There's been a little bit less validation of it. I'm really looking forward to seeing, again, those matches with autopsy proven
Yeah,
cases,
right, right.
as well as individuals first at the time of diagnosis. So I think it has a lot of promise. I think a couple different ways of processing the skin biopsy has
Hmm.
enormous promise. So I'm really looking forward to seeing that data.
Hmm. Okay, great. If there are no more questions, if I don't see any more in a second, we will wrap up then. Thank you so much, Dr. Poston. I appreciate the great talk.
You're welcome, and thank you all for spending time with me on a Friday afternoon. And thank you so much for Robin for the invitation. Have a
And
great weekend.
enjoy your cats.
Thank you.
Bye-bye. And
Bye.
everyone will post the recording and Dr. Poston's slides and the flyers that she mentioned for the studies. We'll post those on our webpage soon. Thanks very
Wonderful.
much.
Thank
Bye.
you. Bye.